Hello, and welcome to Overreactive. I'm Dr. Rebecca Dunsmore-Sue.
And I'm Dr. Amy Bodish, and we are your expert guides on the strange and often uncomfortable journey that is perimenopause.
Hello, welcome back to Overreactive. We're so excited you've joined us today. And we have a very special title for this session. Amy, you want to go with it?
Peri-What-Now? This is one of my favorite episode titles because I will talk to patients or my friends or, just other people, acquaintances, whatever. And I say, oh, well, I'm writing a book or, doing a podcast, or I focus my practice on perimenopause. And so many times people look at me with this really confused expression and they're like, Peri, what now?
Yeah.
And it's a little bit of a confusing time because there are so many different words out there. There's premenopause, there's perimenopause, there's postmenopause, there's surgical menopause. People talk about the menopause transition. Trying to understand exactly where you are on the spectrum and what these words mean, I think is helpful for patients. So I think it would be helpful, Rebecca, if we started with some basic definitions. What are we talking about?
I totally agree with you. I always like to point out to patients that to a certain extent, we don't always know exactly where you are in this transition. It is a transition. The two of us would love it if there were a simple blood test that told us everything. Wouldn't we?
It would make my life and your life so much easier.
So much easier.
If someone could do that, that would be great.
Yeah. And we'll get into that a little bit later. Let me start with premenopause. So basically, that's your reproductive life cycle. So you're releasing eggs at some sort of regular clip, whether that be every 28 days or every 35 days, or maybe not so regular a clip if you have something like polycystic ovarian syndrome. But your hormones are sort of doing somewhat of the same thing every month or every X number of days to get an egg out for ovulation and hopefully fertilization. At least your body hopes it's fertilization. And that's premenopause.
And it takes up, a large percentage of kind of late teens, 20s, and 30s on average for most people. You're in this, what we call premenopause. And it's a nice phase because things are relatively, for most people, but not everyone, relatively predictable, which is kind of helpful. And then we enter into what's called perimenopause. And perimenopause is that time kind of in between premenopause, where we have these wonderful, for many women and many patients, predictable sort of hormonal cycles. And it's the time in between these normal, predictable cycles and the time where we stop having cycles at all. So where our ovaries go into retirement, so to speak. And so perimenopause is that time in between, and it can last a couple years. It can last a decade. Typically, it happens when you're in your 40s, but it can happen for some people earlier than that. It can happen for some people later than that, but that's sort of the typical time frame where we talk about it. And this is where I use really scientific terms such as wackadoodle and bananas to describe your hormonal cycles, because they are starting to get wackadoodle and a little bananas.
We have no one thing we can point to that says, okay, that's when you started perimenopause. Remember, all of this is a spectrum. Where the beginning of perimenopause is, who knows? It's whenever you sense that something is changing and you're symptomatic from that, then we can call it perimenopause. I had a patient just the other day who said, I'm 38 and I feel like these things are changing. My moods are changing. I have more anxiety. I have all of these symptoms. My periods are still pretty regular. And I've seen 3 doctors who've all said, nope, can't be perimenopause. I said, sure it can. Let's call it perimenopause.
Mm-hmm.
It doesn't matter. If you're feeling something changing and it feels like it has something to do with your cycle, it's coming in a cyclic manner, I'm happy to call it perimenopause. Your perimenopause may be 12 years long. You may be a more sensitive person. But there's no one guidepost or marker that tells us, oh, yes, that was perimenopause. Like at this point, you have suddenly started perimenopause. It's a spectrum.
And like you said earlier, there's no blood test to tell you, quote, where you're at in this
Right.
process. And
Although many people will happily sell you something.
yes, they will say there's a blood test that can tell you, but we don't have a blood test to predict how far until you will go through menopause, which is the next little phase we'll discuss.
Yeah.
The other interesting thing about perimenopause is many healthcare physicians, providers, and lay folks will think, oh, I'm having normal, predictable periods, or my periods haven't changed, so therefore it can't be perimenopause. And it's almost sort of classically taught that perimenopause is once your periods start to become irregular, but that's not always the case, right? And so some people will have these clockwork periods, but have all of these other symptoms. And that doesn't mean it's not perimenopause.
So let's move on to menopause. We talk about the menopause. Well, the menopause is a day. It's that day when you have not had a period for 12 months. You have officially reached the menopause. And then pretty much everything after that we tend to call postmenopause or after the menopause, which is that one day. Not to say that women won't have a period at, 16 months sometimes. And, does that start the clock over or not? It doesn't really matter.
Right.
But in menopause or postmenopause, what I tell women is your ovaries are not functioning. By and large, they're not making estrogen, they're not making progesterone, and they're not growing eggs for release. Doesn't
Right.
mean your brain's not telling them to, and that has a whole host of symptoms all by itself, but they're not responding. Now, as we'll talk about in a whole episode of its own, they are still making testosterone, but that's a separate issue.
A separate hot topic.
Yes.
Stay tuned.
Separate hot topic.
And then the menopause transition is basically all of perimenopause until we kind of know that you're in menopause. And so we don't know you're in menopause. It's more of what we call a retrospective diagnosis. And so once you've, for the textbook purposes, gone a full 12 months with no bleeding, you're then considered in menopause or through the menopause transition. But we don't know that you're in that year yet until you've gone a full year. But as you said, Rebecca, our bodies don't read textbooks.
No,
So we have it.
unfortunately, gosh,
No,
our
it'd be
jobs would be so much easier.
so helpful if they could just really fall in
Just
line.
hand everybody the textbook. You're going to do it this way.
It'd be so nice if there was a blueprint because there's no blueprint for this. And
Yeah.
that's what's so frustrating.
Yeah.
And it's so different for everyone. So it can last, like I said, a decade, 12 years, or 3 years. Like
Yeah.
it's just,
Everybody's different.
everyone's so different. Yeah.
And then I think it's important to mention surgical menopause. So surgical menopause is when your both ovaries have been removed. And I like to specify that because some people have a hysterectomy, which is the removal of their uterus,
Hmm.
but their ovaries remain inside. They're not menopausal unless they were already menopausal when that was done. The ovaries will continue to function whether or not there's actual visible bleeding from the organ that bleeds, which is the uterus.
Right. Hmm.
But if both ovaries are removed, we basically consider you immediately menopausal. And that's because the ovaries are no longer functioning and they're not going to start up again. We don't need to wait 12 months at that point.
And surgical menopause is different. And this podcast is about perimenopause
Right.
and sort of that time leading up to it. But you could be perimenopausal
Mm-hmm.
and then have a surgery where both of your ovaries are removed. And then you're there for,
Yeah, tell me about
yeah.
it.
So
Been there.
you've been there. You've been there. So how fun for you.
Yeah, it was great. So I think what we really need to do now that we've set some definitions and said, okay, these are sort of the words that we're going to use throughout this podcast. What we really need to do is explain, well, what is actually going on behind the scenes in perimenopause? Because I think that's what's so vastly misunderstood, even in the medical community.
Oh, absolutely.
It's why people think there should be a blood test or you can just check your hormones and know where you are, is because they don't understand what hormones are doing during this whole time.
Thus, the title of our podcast.
Yes, overreactive. So I think the first thing to explain is what do your ovaries do when you're just having regular periods, when you're premenopausal?
Hmm.
Because I don't think we do a very good job of educating people in this country about our reproductive health.
Right.
In some schools, I won't even say all schools, they sort of teach you how not to get pregnant. But they don't really teach you what's normal. What are some of the patterns that we see when your ovaries are functioning? And how do they get to where they're going? So, the first thing to understand is that the ovary as an organ has a purpose. Its purpose is to make eggs every month, which it then releases to go out into the world and meet up with some sperm and become a fetus. And so every month, the brain starts to signal with this pulsing signaling to the ovary that says, hey, new month, let's try. And it says, find some eggs, let's recruit a few, let's get them going, have them start trying to mature. Usually, you recruit several follicles or pre eggs, as we like to call them, every month. And then one just seems to succeed better than the other ones. It wins, so to speak, and so it becomes bigger, and the other ones sort of back off. And all those cells around that pre egg are making estrogen, really perking it up and making it big and beautiful and ready to go.
Hmm.
And then it will explode out of the ovary. I like to use explode because sometimes it really does explode. Some people actually feel it. It's called middle schmerz.
I just love middle schmerz. I mean, what a word.
Um, And then that all those cells that are left behind where that egg was developed start making progesterone. And that progesterone sort of helps to get the cilia in or the little fingers in your tubes,
Hmm.
moving that egg along towards the uterus.
Hmm.
And if it meets up with a sperm, then it'll implant in the uterus as a fetus. It may or may not succeed, but at least it's done its job. If there are no sperm around, then it just sort of floats on through and goes out. And at the end of that cycle, when there's no fertilization, all the hormones drop. The estrogen comes down, the progesterone comes down, and that's a signal to your uterus to shed the lining it had built to protect a pregnancy. And that is your reproductive cycle. And if everything goes according to textbook, you have about 14 days of estrogen peak to get that egg out. And then once you release the egg, you pretty much have 14 days for it to implant or you start bleeding.
Right.
And that would be a normal, regular cycle. And during our reproductive life, those peaks of estrogen and progesterone are pretty predictable every month. They're mostly the same. Some people are more sensitive than others to it. Some people already have some mood symptoms as that progesterone drops, especially at the end of the cycle. If you haven't gotten pregnant, and a lot of
Right.
people can get symptoms during that time. Some women even get depression during that time. That's called premenstrual dysphoric disorder, but it's predictable.
Which is nice. Our body likes things that are predictable. And
Yes.
just a
Our brains
couple,
like predictable.
I know our brains really like predictable things. So, just a couple of things I wanted to add to that. The other lovely side effect or the other purpose of the estrogen is to help build up the lining of the uterus
Yeah.
in a hope, in the hopes that there's fertilization. So, it's basically like laying the beautiful 700 thread count sheets for
Mhm.
your fertilized egg to just kind of bed down in. And then when we don't get pregnant and the progesterone and estrogen levels drop, it's that drop in progesterone that signals to the uterus to shed that lining. It's like you made the guest bed, the guest didn't show up. So you're like, fine, whatever. I'm just going to strip the sheets and I'll start
Yeah,
over next for the next guest.
exactly.
That's kind of one of the nice sort of parts that the estrogen does, which is really helpful. And then the other thing you were talking about, how the drop in those hormones can trigger some symptoms. And one symptom that can be really common for people are headaches and migraines. So if you're someone who has menstrual migraines, it's because your estrogen levels are falling,
Yeah.
which can come into play when we're talking about some of the symptoms that people can experience in perimenopause.
So we've talked about the normal reproductive time and that sort of even cycling that we do for years and years and years.
Hmm.
So why don't you explain to the folks, well, what's different in perimenopause? I'm still having periods. So isn't that what's still happening?
It should all be fine.
Yes.
Well, this is where I get into my very technical terms of wackadoodle and bananas. So even though sometimes the pattern might be there, there's so many different ways the hormones can go during perimenopause. And one of them is that the pattern is still the same. So your ovaries are still making estrogen and progesterone in a relatively predictable pattern. Therefore, you're still having periods in a relatively predictable pattern. But the highs and lows of the estrogen within them, it's almost like instead of having a beautiful, smooth roller coaster curve, it's like a giant, jaggy line as things are going up and down and up and down. And the pattern might be the same, but the hormone levels themselves are just kind of very erratic.
Yeah, I like to explain to people that, during your normal reproductive life, you got a whole host of eggs to choose from, and some of them are going to be great every month. And then you get to perimenopause and you're selecting from like the B team.
Right.
These eggs suck.
I mean, I think B team is generous.
Okay, probably the D team.
You're really pulling deep in the bench.
Yeah, you're heading deep in the bench. These eggs are old, they're tired, the brain is signaling, and the ovary goes, This is all I got. And it's like, yeah, try harder. Find five more.
Right.
Give me more because none of these is good enough. And so you just get these huge spikes of hormone because your ovary is recruiting everything it can find off that bench,
And
trying
they're
to get
not,
something that's going to make it all the way out to ovulation.
it's doing its best. And sometimes the ovary, they can get an egg out with a lot of work and a lot of effort. And that's, again, explaining the wackadoodle bananasness that's occurring at this point. But sometimes it can't. And then sometimes it like sort of gives up on the first try. And
Right,
so it'll just start recruiting another batch. It's like, all right, forget it. These people aren't working. I'm going over here to this group. But now you have two groups
right.
that are
Both
not,
trying to get there.
they're both trying to get there. So now your estrogen levels are going even higher.
Right.
I mean, really crazy. These are some of my favorite things that happen during this time.
I know we call it loop, luteal out of phase ovulation.
I mean, it's so fun. I
I
just
know
love
it's
that.
got a great name.
We're so witty in medicine sometimes.
Yeah, yeah. I thought
You know,
we're also
we,
just hormone geeks. You do realize that, right?
right. Well, yeah, no, it's true. I mean, the things I find interesting.
I know.
I mean,
That's why we get
kind of,
along so well because I
I
find it
know.
interesting too.
I do feel sometimes for this is a total aside. I feel often for my friends and family when I'm having a conversation, what I find to be very interesting, and they're just trying to eat dinner. So,
Yeah. Well.
you know, so that's why we're friends.
Yeah.
So you've got these two different groups, and these estrogen levels can go crazy. And sometimes both of those groups will ovulate. Sometimes none of the groups will ovulate. Sometimes one will ovulate and then the other ovulate later. I mean, it's just chaotic.
Yeah. And what happens hormonally is once you get to ovulation and it doesn't fertilize, you still have to drop off that cliff. It's just the cliff is a lot higher and the fall is a lot worse.
Yep,
And
exactly.
that's why we typically see a huge upswing in mood symptoms, especially in the week or so before menses
Right.
during the perimenopause, even if you're still pretty regular. It's why sometimes we see two bleeds in a month. One of the earliest changes in our period patterns is actually they get closer together because you probably got a couple sets of eggs going at any given
Right.
time and they're just ovulating a little bit off. And so you get a period every 3 weeks now
Right.
before you start skipping. It's predictably unpredictable.
Yes, exactly. And so patients will come in and they'll have this, they bring the calendar. They're like, I used to be able to set my clock by my periods, like absolutely. And then you can just see the calendar that and it's just bananas. Like you said, every 3 weeks. At the beginning, sometimes, like you said, they're closer together or you're bleeding more frequently, which is really annoying
And heavier
and
because the
heavier.
estrogen levels are so high.
This is when I liken it to, I think we're going to probably have a whole episode on periods, but where I liken it to the second puberty. Because if you remember being a teenager and like bleeding through your white pants at school,
Right.
that's going to start happening again, or it can start happening again. You're like, I'm tying like sweatshirts around my waist again. I thought I left that behind when I graduated from middle school. But you're like, no, no, welcome back to the land of bloody chaos.
Ugh. I mean, that's the best word to describe perimenopause, right? It's chaos.
Total
It's
chaos.
hormonal chaos. It's uterine chaos. And, we don't mean to make it sound horrible. I mean, it can be horrible. Let's be honest here. And some women breeze right through it. They're like, oh no, my periods were regular and then they just stopped.
I would love to study them.
I know,
Like,
seriously.
why? They're like, I had absolutely no symptoms, and then my period just went away, and I'm just totally great, and everything's fabulous. And then for the rest of us, mere mortals,
Mm-hmm.
and I think sometimes what's also really difficult about this time is sometimes the changes are subtle, and you almost feel
Right.
like you're being gaslit, where you're like, something isn't right.
Right.
Somebody is like, psychological warfare is happening, where you're like, all these different symptoms are happening. You don't exactly know what's pinpointing. They can change. So
Mm-hmm.
sometimes you're super moody and irritable and anxious, and then all of a sudden that resolves. And the next thing you know is you can't sleep. and then you have no libido, and then your
Mhm.
periods are whacked. So everything can be a little bit different and not necessarily all at the same time. So it's
Yeah.
tough.
And every month is choose a new adventure. Remember those books when we were teenagers? Like, go to page 77 if you want this, or go to page 58 if you want this. Yeah, that's pretty much perimenopause. It's never the same story twice, right?
No. And because we have estrogen receptors literally everywhere, from the top of our head to the tips of our toes, all of these different body systems can be impacted. They might all be impacted at once. They might be impacted at different times. Like you said, it's kind of a choose your own adventure of what we're going to experience.
Right.
And often people, when they hear the word menopause, so even when it's in a perimenopause,
Mm-hmm.
they'll think hot flashes and night
Right.
sweats.
Right.
That's your classic. You remember your mom opening up the freezer and just like standing there getting the cold blast when you were little or whatever. And perimenopause, it can be sneakier than
Mm-hmm.
that, not quite as obvious. And so that can be hard. And you're like, is it my hormones or am I just like done with what's happening in my life?
And it can be both. Let's be honest.
Yes.
Most of us in perimenopause are in an age where we're kind of done with some of
Hmm.
the crap we have to deal with every day. So, is it all perimenopause?
Right.
Some of it may just be a bad situation. That's allowed too. These
Yes.
two things can be true. There's a great saying we use in medicine: true, true, and unrelated.
It just may be happening all at the same time. So that's why it's also kind of an interesting time, right?
Right.
Because there's so much happening socially. We have aging parents, perhaps we
Hmm.
have kids
Who are now teenagers, perhaps.
or teenagers.
It's always great when you're perimenopausal and you have a 12-year-old.
Oh, yes, that goes really well.
When everybody's doing this up and down, crazy, unpredictable hormone thing.
Right. Yes, exactly.
That goes extremely well.
Yeah, that works well for everyone involved.
Absolutely.
I'm pretty sure spouses across the United States just like dive under covers when they realize what's happening. They're just like, no, this is going to be collateral damage. I'm getting out of here. There's no winning this situation.
And there really is no winning.
There is nothing. Yeah, no, sorry.
So I think one of the things that confuses patients and confused me for a long time is, well, if the same thing is happening to everyone, for the most part, slightly different patterns, it looks a little bit different in everybody, then why do some women breeze through and some women are dramatically affected? And everywhere in between, what's different about these women? Because we know they're all going through these hormonal changes.
This is a natural thing. It's supposed to happen. It's not a disease. It doesn't need to be cured, but it does impact people so differently. And I find it really hard to predict. So what do you tell patients when they ask you that?
So I talk a lot about hormone receptors. So, we think of there being an estrogen receptor and a progesterone receptor. That's not true. There are many varieties of these receptors. We know at least of A and B in the estrogen world. There are probably multiples of the progesterone receptors. And your unique genetics determines which of those receptors exist where in your brain, in your skin, in your bones, all of those things. So you have your own unique pattern of receptors to read the hormonal chaos.
Yeah,
And so some people's receptors just don't seem to cause them as much trouble when they read these weird levels, and other people's do. That's the best I can get. I don't think we know better than that,
I know.
really behind the scenes what's going on. There's a great study. So we promised you data.
Rebecca's so good at data, by the way.
It makes my heart sing. I don't know. I'm geeky that way.
Yeah.
But there was this great study that we could never convince people to do now. But Dr. He did a study back in the 90s where they basically took blood from women in perimenopause across the course of a year, and they tracked their cycles throughout that year. So this is really sort of a landmark study. One of the main reasons we know what's happening in perimenopause, because basically these are women who are already having a regular cycle, so a little further down the pathway. And what they showed is like 1 month, their pattern would be totally normal. Normal estrogen, normal FSH, that follicular stimulating hormone that everybody's heard about that's supposed to tell you if you're in menopause.
And that's the one that comes from your brain
The one from your brain that's telling your ovary to
and
work.
it talks to your ovaries. Yeah.
Yeah. And then the next month, they're in the menopausal range. And then they're somewhere in between. And then they're really normal again. And then they're menopausal again. And over the course of a year, all of these were true in one person.
That's wild.
And it's wild, but that's what's happening between your brain and your ovary during this year. It's also why we can't test your hormones and tell you where you are, because all that test tells us is where you are today.
At that literal moment, because it can change even within the course of 24 hours.
Right. So all a hormone test tells us is what your ovary is doing today, and who the hell knows what it's going to do tomorrow.
We just don't know. And this is another reason why I think about this as a second puberty, because when you think about when your periods start, so let's say you're 12 and your periods start, they usually don't start and then are super predictable. They're not like, oh, okay, the minute your period starts, now I'm on this nice, predictable 28-day pattern. It can take years for your ovaries and your brain to work out their signaling because as a 12-year-old, your brain is still developing. Everything's still developing. So this pathway takes a while to develop. And it might not be until your early 20s, for some people before you're really getting into, you're really like, as we like to say, you're cooking with gas, kind of thing. And it's the same thing on the way out. And it's why perimenopause and puberty are so similar because now the hormonal signaling is starting to fall apart. So it took a while for it to really get into sync. Now it's falling apart, but it takes a while to fall apart because the ovaries and the brain have been good partners for a long time. They want to keep working together, but the working relationship is changing.
It's going downhill.
It's really just
Yeah.
deteriorating. So,
Yeah.
but they're holding on
The other thing that I often talk to women about in terms of like testing hormones, because this comes up a lot. You know it does, right?
all the
And
time.
we want data. Like we as humans, we want the data. Like show me something that tells me X, Y, or Z. But one point I really love to bring up and I want to emphasize to everybody is that we don't test hormones in the perimenopause because if you come in and tell me you have these 6 symptoms of perimenopause and they are impacting your life, I'm going to treat you.
Hmm.
I don't actually care what your hormones are. Because what if I did a hormone test and they're totally normal? Would you like me to say, oh, no, no, you're not in perimenopause. Don't worry about that. You go on. No, you're symptomatic. I need to help you, right? You're coming and asking for my help. I'm going to help you. And I'm going to titrate that help until you feel better,
Right. Hmm.
not some artificial number that is
Yeah.
only valid for 24 hours, right? If that.
And it's different than if you think about, because a lot of women will have, for example, thyroid issues.
Right.
And with thyroid issues, it really is driven a lot by the number and the blood test. But this is very different. They're both hormones, but this is really different.
Well, thyroid hormone is supposed to be the same
Yes,
all of the time. You can titrate to something that's not changing.
right. It's a therapeutic window of this is where it should be. Whereas estrogen levels, even throughout a normal premenopausal month, vary dramatically.
Right. I think the normal range on our lab is between 5 and 500
Right.
or 12 and 500 or something like that because it varies that much through a normal cycle.
Hmm.
And as I like to say, I don't know where in that 12 to 500 you're going to feel better. You might feel better at 20, or you might not feel better till 50 or 100. I just need to titrate till you feel better. That's also why we don't follow the levels as we're treating, right? Because it doesn't matter to me what exactly the level is. I'm going to put you on a low, steady dose and we're going to titrate it until you feel better.
It's a really different approach than I think people will find maybe outside of more traditional medicine paths.
And I think it makes a lot of doctors uncomfortable. We're really good at reading numbers and titrating things to numbers, but this is a much more holistic approach and it's harder. It takes conversation.
Right. I mean, this is the art. If you're treating a blood pressure, we have a target number and we're going to get you to the target number. You're treating diabetes, there's a target number. We're going to treat to that. This is different. It's the art of it. It's gray. Doctors like black and white.
We do like black and white.
We're very comfortable in the black and white. The gray is where we start to get a
Gray
little,
is tough.
yeah, gray is hard for us.
Right. And it's also gray in the sense that, for some people, it's confusing that someone could be having hot flashes and still have estrogen around, right?
Right.
Or having night sweats and still have estrogen around because things are coming and going. And a lot of these symptoms, although we've classically said, oh, it's the loss of estrogen that causes X, Y, and Z, In fact, it has a lot more to do with what's going on hormonally in your brain
Right.
than the estrogen itself. It's the signaling from the brain trying to talk to that ovary and the way the brain is signaling. Not that it is yes or no, but it's a pulsing thing, and how it pulses makes a huge difference in our temperature sensing, which is in a different part of the brain.
Right.
And it makes a huge difference in lots of other things as well. So even though you may still have estrogen, you can have the symptoms of menopause, which can be very, again, it's gray, it's confusing.
It's confusing for patients, it's confusing for doctors.
It is. It is. So be sympathetic with us. It's not as easy as some of the other things we treat,
Right.
and it's poorly taught. You know, how many lectures did you have on this in medical school?
I'm gonna guess 0.
Yeah, I think I had one.
Oh,
30 minutes of half the population's life.
right.
30 minutes seemed sufficient. Got a little bit in residency, but I was also in an institution where, like, I had people who were at the ground floor of the Menopause Society.
Right.
They were there, and I still got pretty limited teaching on it.
Which I think is really surprising because a lot of patients will come into their OBGYN and be like, how do you not know about this?
Yeah,
This is about ovaries. This is literally the focus of our training.
right.
But this perimenopause and menopause are just not, haven't traditionally been sort of areas of focus and areas of
No,
education.
they did a survey study a couple years ago, and only 20% of OBGYNs felt like they had formalized teaching in
Right.
residency about menopause. And when they surveyed primary care doctors, it was even lower.
Oh, right.
I'm going to make a very political statement here. We haven't studied it because post reproductive women are not valued in our society. So why study that? Right?
Well, what value do we bring?
Right.
We can't have babies. So
Right.
therefore,
Right. But I
mm,
think also, like, these symptoms of perimenopause and menopause were considered nuisance symptoms. Like, oh,
yes,
that sucks, but it's not going to kill you. Therefore, we're not going to worry about it.
right,
And I'm going to make two claims on that. Number one, it can kill you because we know that the incidence of suicide goes up significantly in the perimenopausal years. So it can absolutely kill you. Secondly, we're at our most functional. We're hitting the top of our careers. Our kids are getting bigger. We're really at a point in our lives where we can contribute, and contribute massively. And if we derail because of something that can be treated, that's not good for anybody, right? Not just for the woman herself, but for everyone she interacts with her family, with her career, with her job, with, say she's a physician, with her patients.
right.
I'm biased, but I don't think these are nuisance symptoms.
No.
But I think we tell ourselves that too, right? How many women have come in, they're like, I've got all these symptoms, but it's just menopause. I'll be fine.
Right. It's fine. I mean, and for some people, it is fine. But for
Hmm.
so many people, the impact on your ability to live your life, your quality of your life, and to live your life, not just get through it, but actually enjoy it and live to your potential is severely impacted. And we also know that sort of the earlier onset and severity of, for example, your vasomotor symptoms can be related to cardiovascular disease risk. And so there are things that we need to think about. So yes, as I said earlier, this is a natural process. It's not a disease. It's supposed to happen. That doesn't mean that there aren't things that we can do to optimize it. And it doesn't mean that the transition for some people is really bumpy
Yeah.
and they really suffer, even though most of the time a hot flash is not life threatening. We get that. But when you're putting a constellation of symptoms together and the impact it has on the quality of people's lives, as you said, the risk of suicide goes up, the quality of your life goes down. There's collateral damage. There can be divorces, impact on your relationship with your kids, your job can suffer. I mean, very serious, significant things can happen if we don't take this seriously and help people live their best lives during what can be, as we've said, an extremely chaotic time.
And I think a good point also to make, because I think we may be, we may get pushback. Well, you're telling us we have to treat this natural transition. No, we're not.
Mm-mm.
You do
No,
not have to treat this. You will get to the other side with no treatment whatsoever, most likely. I mean, there's rare occasions where that's not the case. But what I like to tell women is Nobody's waiting at the finish line with a blue ribbon for you because you made it without hormones. Nobody cares.
Right. It's your own personal journey. However you want to get there, it's on you, but you're not going to get bonus points for
No,
suffering.
there are no bonus points. There should be bonus points.
But there's no bonus points.
There's no bonus points.
So it's really however you want to go through the journey. And
Exactly.
we're just here to educate you, to give you the information that you need to make the best choice for yourself and how you want to tackle this phase. And that's it.
Right. And that's such an important point. I want to reemphasize it. Our job is to give you all of the information so that when you make that choice, it's an educated choice. Because it's not really a choice if you've been told that hormones are dangerous and you just need to stick it out.
Right.
What we want you to know is that there are lots of safe treatments.
Hormonal and non.
This is what they can and cannot deal with.
Hmm.
And it's your choice about whether or not to use those, but also to give you the information that there are all these other things being sold out there as choices that really aren't effective and you're just a waste of money or could even be harmful. So that's really our goal in doing this, is not to say every woman needs hormones, because every woman doesn't need
Right.
hormones,
Totally agree.
but to say, here is the pantheon of what is safe. Here are the things that do not work. Go out and find the right path for yourself.
It's choose your own adventure.
Exactly.
You just want to make sure you have the information so
Mhm.
that you can make the right choice for yourself.
So I think next episode should really focus on, well, what are those choices?
What are the tools that I can use to make this as enjoyable and as fulfilling and have the quality of life that I want to have? What are the tools that you can give me to make this better for me?
And how do they work differently in the body? Because I think there's a lot of confusion about that, because not all hormones are created equally.
Spoiler alert.
But we'll talk about that next time.
So, looking forward to going into much more of our nerdy hormonal talk on the next episode of Overreactive.
Yeah, you guys are in for it. We really like talking about hormones.
Buckle up.
Buckle up. It's going to be a fun ride. And remember, you're not crazy. This is really happening.